Hello and welcome to Slide Review. So today we are looking at the third installment in our GU series where we'll be spending a little bit of time on some of the bladder lesions that you can encounter. As always, we start with our standard disclaimer, and as always, we welcome questions, comments, and let's get started. So to begin with, we're going to look at a few inflammatory lesions. So this is case 1. At first glance, what we see is that it seems very busy. We have some areas that maybe are a little polypoid or maybe even cystic, and it's generally very blue. For the most part, these will be the areas that you want to take a look at, but let's just go down and see what we have. So we indeed do have areas that are a little cystic in appearance. Some of them look like maybe they have some material on the inside and some dilated vessels as well. Some macrophages. And some of them have almost like slit-like areas. And not too much happening within the lamina propria itself. But you do get the sense that maybe there's some glandular type areas. See if we can find anything that's really convincing. Although the slit-like areas do help you quite a bit. Usually with these lesions, they're so busy, but at the same time, when we're looking at the urothelium, it's relatively bland. And we definitely see areas that look like, like maybe is this mucosal lining instead of just a urothelial lining. And some areas that look really edematous, and those are the more polypoid areas that we've been seeing. And as you drive around, and obviously spend more time looking at this case than what we're able to spend during lecture, you'll see that there's more and more of these areas. And some areas where maybe the stroma looks a little busy with some chronic inflammatory cells. Again, more of those glandular type areas and more macrophage activity. So what are we looking at here? Well, the areas where we have the more slit-like expansions, those are more of our cystitis cystica. And then the areas that look like glandular development, so maybe that's probably not the best example. Maybe more stuff like this. Trying to find a really good area. This doesn't look too bad, neither does this. But the areas that looked more glandular, maybe in the beginning of the case was a bit of a better example. Those are your cystitis glandularis. This is a little better. And all of these are in response to irritants, whether that's inflammation from recurrent UTIs, or even things like patients who have Foley catheters or indwelling catheters. But this is cystitis cystica aglandularis. And these are often incidental. They can appear nodular on cystoscopy, so you can imagine why they would sample these things. And as I was saying, association with recurrent UTIs, chronic cystitis, bladder exstrophy, reimplantation post-surgery, neurogenic bladders, a lot of different things can cause this. It typically occurs within the trigrome, but you can also see it within the ureter as well as the renal pelvis. And as we were saying, they are these nodular papillary type lesions that grossly will be identical to papillary urothelial carcinoma, so yet another reason why they would sample them. Cystitis cystica is involving your von Brunn nest, And remember, von Brunn nests are invaginations of normal urothelium, but they develop these slit-like or cystic-like spaces within the lamina propria, and that's what you're seeing. So cystitis cystica, here we have fluid, and this is present in about 60% of bladders, so it's really common. Cystitis glandularis of common type is when we get more columnar cuboidal line glands in the lamina propria. And I think that's what our case had, was cystitis cystica, as well as cystitis glandularis of common type. So you can say cystitis cystica glandularis, and that's totally acceptable. Common type obviously is more common than our intestinal type, which is intestinal metaplasia. Usually intestinal metaplasia we'll see within the bladder neck as well as the trigrone, and we may also see this present as a papillary polypoid type mass. And obviously we can see goblet cells present within that because of the mucus that would be present. Ureteritis follicularis just means when you have this involving the ureter, that's a ureteritis, and your mucosa becomes more granular, and this is because you have some lymphoid follicle expansion, okay? So grossly, it's gonna appear granular. So cystitis glandularis of the usual type, CK7 positive, CDX2 negative because there's no mucus, and CDX20 negative. When we're looking at intestinal type, we're going to have almost a complete, well, literally a reversal of that, where we have CK7 negative, CDX2 positive for our mucus, and CK20 positive. Again, intestinal metaplasia. So CDX2 should be positive, your CK20 will also be positive. Beta-catenin can also be positive. Cystitis glandularis should be, cystitis glandularis of the usual type will have membranous staining of beta-catenin. There's no molecular for you knowing. Again, this occurs in 60% of bladders, so it's extremely common. Your differential is going to include adenocarcinoma of the bladder, endocervicosis, and you'd want to think maybe of metastatic lesions to the bladder as well when you're looking at intestinal type. Treatment, so remove whatever's irritating the bladder, and that'll help. And they may or may not do long-term antibiotics. ABX is antibiotics. Here we just have more of your usual type. So again, you can see this definite glandular type epithelium. And intestinal type, this looks almost like we're in colon. If someone didn't tell you that you were in bladder, you had some urothelium there, it might be difficult to actually tell off of a very small biopsy. Prognosis, there are some case reports of progression, but pretty much this is benign. It's just in response to irritation. Case 2. So this is a lot less impressive at low power, perhaps, from our previous case. What we see are these areas of very dense eosinophilic staining in this background of maybe falling apart tissue. Hard to tell. But if we go in, what we see is we have very thick cuticles, and we have some internal organs. See if we can find anything else. But obviously we are within the parasite realm, okay? And when we're talking about bladder, oh, here we go. If we're talking about bladder and parasites, the first thing that should always come to mind, because they love to ask about it in the books, it doesn't necessarily mean that it's what we see anymore in reality, but they love to ask about schistosomiasis, okay, and specifically schistosomiasis hematobium. So that's what this is. Okay, so you have a lot of the organisms, okay, that are present within the bladder wall, and that's what they like to do. So this was just a really impressive case for that. Again, endemic to parts of Africa and the Middle East. We always think of the Nile River Valley in Egypt because that's the classic example that they like to give, is the fisherman from Egypt who has gross hematuria and ends up having schistosomiasis hematobium. So I have a lot of information about different presentations of schistosomiasis, as well as the lifespan that you'll see of the trematodes. Here, obviously, we have the worm. If you're looking at the eggs, these are known to have terminal spines, but as with any micro, when we're looking at eggs and whether it's lateral spines, terminal spines, it's really difficult to actually tell this on H&E. So having your cultures or your MALDI-TOF is actually going to be more helpful in figuring out what you're looking at. Grossly, you may see eggs or even calcifications either in the urine or within the bladder. Okay, all these being, yeah, lots of eggs. Again, same picture of that terminal spine. On microscopy, this, again, it's a parasite. It's irritating the bladder, so you can see ulceration. There may be necrosis or eosinophils. Remember, our eosinophils really clue us in to there being a parasite, and there were lots of eosinophils that we didn't really go over, but there were lots of these eosinophils within our case in particular, and you may or may not see the calcified eggs. There can be flattening or thickening of the bladder wall. Again, it just kind of depends where it is in the bladder and how it's reacting to that. And you may or may not see keratinocyte dysplasia, okay? So squamous dysplasia, squamous metaplasia, so all those things to keep in mind. For your stains, there'll be acid-fast bacillus positive, right? Schistosomiasis mansoni and japonium for eggshells, those will be positive. Lots of different molecular that you can look at, but really the important ones to know are your FR3, which is more than a third of your cases, and that can lead to low-grade papillary tumors, as well as deletions of P16, INK4A, and inactivation of both your P53 and RB, so chromosome 17 and chromosome 13. And we tend to see these when we have associated carcinoma in situ, CIS is carcinoma in situ, as well as invasive high-grade tumors. One of the things that we're going to go over, but you should keep in the back of your mind, is that low-grade tumors are very rare to invade in the bladder, okay? But lots of other things to keep in mind, and loss of 9P is also important. Differential, you'd want to think about, is this just cystitis with calcifications? That can totally happen, but these will be irregular. You won't see those prominent spines, okay? So even note here that I'm not saying terminal spines, lateral spines, just prominent spines. And we can also see urine crystals, all right? So urine crystals will polarize, and they can also cause a lot of inflammation and irritation within the bladder wall. Treatment, well, for these worms, praziquantel is your #1 go-to, but they will use metrophenate, and they can use corticosteroids for severe disease, because remember, you might want to tap down that immune response to this. Okay, 5 to 10% of patients will progress to carcinoma. Most of these are going to be squamous cell carcinoma, but you can see also adenocarcinoma, so adeno-CA. Urothelial carcinoma is extremely rare in these cases, but it is something to keep in mind. Even though we're in the bladder, squamous would be the most common thing. And your poor prognostic factors is mostly having chronic infection and complications associated with that. So regardless of what those complications are, having obviously more complications can confer a poor prognosis, because the patients may not be able to respond to treatment as well. So that's your schistosomiasis hematobium, and that's the end of our inflammatory lesions. So we're going to move straight ahead to our epithelial lesions, and you'll notice in your handout that I included a page with a lot of excellent pictures from ExpertPath that go over what normal urothelium looks like, the difference in lamina propria when we're looking at the trigone, muscularis mucosae versus muscularis propria, because all these things are important, and there's also a little something in there about your von Brunn's nest, so make sure you check that out. Moving on to our epithelial lesions. This is case #3. So this case looks very similar to case #1. It looks very polypoid. Maybe some areas are a little more hemorrhagic. And otherwise can't tell too much at this power. So let's just go down and see what we see. And what we see are lots and lots of relatively, well, actually, I think this is all normal urothelium. Some areas that remind us of cystitis cystica. Not seeing anything that looks like cystitis glandularis. Oh, maybe here, maybe. But there's things that like we also aren't seeing, like, you know, there are some inflammatory cells within your stroma, but this is within the bladder. That is totally normal. And here we have some blood, so I don't necessarily want to say too much about that. Remember, these very round, well-defined nests, these are your von Brunn nests. Those are, again, are just normal urothelium. Not seeing too much else. And you know what? That's because we're not supposed to see too much else. Is there an area that really shows it, though? Not really. So what I'm looking for, maybe this, a little more, is you're looking for these clover leaf projections. That's what this lesion is known for. But really, you shouldn't be seeing too much else. It should pretty much just be bland epithelium. We can't say anything about a stalk because I can't really tell like where the stalk is because we have all these fragments. But what this is trying to depict is a fibroepithelial polyp, which obviously can occur within the bladder. But these are extremely rare lesions that we see more common in children, and huge range in ages that they affect, often middle-aged people, men more than women, and they're asymptomatic incidental findings. They like to occur at the verumontanum or the veru, and this is found within the prostatic urethra. And you can also see them within the proximal ureter more often than in the bladder. Shown in ureter. This is definitely ureter here. Okay, so what do we see is, again, we're looking for this clover leaf-like projections and, or club-like projections if you play cards, clubs being one of the suits. And you can see changes that are cystitis glandularis of the common type within the stalk. And it should be a papillary lesion, lots and lots of fibrovascular cores, which is what we're seeing, and dense fibrous tissue. You can also see long papillary fronds. I don't know that ours were necessarily long, but they were very well-rounded, lots and lots of fibrovascular cores. We couldn't say anything really about the stalk because we couldn't really tell where it was, but you shouldn't see prominent edema or inflammation like what we were seeing previously in our inflammatory lesions, and there may or may not be degenerative atypia. If you do see degenerative atypia, it will be within the stroma, not within the epithelium. There's no staining really that's going to help you with this, no molecular to know, so we go straight to a differential, which would include things like florid, which means very much or abundant, cystitis aglandularis, inverted papillomas, polypoid or papillary cystitis, and urothelial papillomas. So you're sticking within the bland, non-malignant realm. So what do they do for these? Well, they're just going to take them out via transurethral resection of bladder tumor. That's what TURBT stands for. So they might even have all this on biopsy. And this is curative. So here just showing you this very bland epithelium with these invaginations. And here, hopefully you can appreciate a little more all these projections. Here we have more lengthy papillary type fronds. And this is case 4. So at low power, we can see that it's very cellular, seems very busy. And the pattern, maybe even at low power, is a little different from what we've seen before. Before, we've seen a lot of cystic lesions, and here it kind of looks more trabecular, at least up in this area. This maybe is more nested. So let's just go take a look at this. And what we see right away, although I think it's maybe somewhat subtle, is there is some peripheral palisading. And this is a trabecular pattern, which means cord-like type patterns. And if we go around, you can see here some fat cells, looks like. Remember, you can have fat within the bladder, so don't be scared if you see like malignant cases and there's some fat. That doesn't always mean that you're outside the bladder. Okay. And this area is kind of interesting too. Again, I think we're seeing some of the fat cells, but I feel like this shows the peripheral palisading a little better. You can see how we have really intensely basophilic cells.
So we are looking at, what are we looking at? What is this?
Bladder. Everything's bladder
okay.
today.
It's, so looking at this thing, there seems to be, it's very cellular. Is this in the power?
This is pretty high power, yeah.
Ooh, okay. It seems to be a lot of fat.
Mm-hmm.
There's also a lot of like cells that's, you know, looks kind of weird. It kind of looks like it's inverted.
Yes.
It looks very exophytic.
It looks like it's growing into the tissue rather than out of it, right?
Yeah. And looking at these cells, just like on higher power here, it doesn't look good. Like you have big ones, small ones, they kind of look, and they're not really streaming in a particular way. Like these ones are going this way, this one's going this way. I mean, I feel like this is like some sort of high grade, inverted high grade urothelial carcinoma, maybe. I don't know.
Not pun lump. So remember, pun lump or papillomavirus urothelial neoplasm of low malignant potential, and that's why we say pun lump, because wow, that's a mouthful. Pun lump will have expansion, so you wouldn't have these trabecular areas. Everything would look more nested or expansile, and there's no atypia. You are not allowed to have atypia with pun lumps. However, you can have atypia with inverted papillomas.
Oh, okay.
Okay? Because I'm not really specifying more. The point of this case was to show you the inverted pattern, which you nailed. So you got the learning point. All right. So these are extremely rare. They're also known as Brunian adenomas, but inverted papilloma is just as good to say. And these actually account for less than 1% of all urothelial neoplasms. We tend to see them in older adults, particularly males, as with most things in the GU system. And these patients may have hematuria, they may have irritation when voiding, and very rarely they'll have obstructive lower urinary tract symptoms. That's what LUTS stands for. There is association with urothelial carcinoma, and urothelial carcinoma can occur within the inverted papilloma. So that is something that we are looking at as well. These tend to occur in the trigone or as well as the bladder neck, and you can see it within the prostatic urethra as well. So just lots of pictures trying to show you that trabecular pattern, the peripheral palisading. These are just really pretty to look at. So we have two different types, the classic type and the glandular type. Our case is a classic type, so that's more what you should pay attention to, at least for the purpose of this lecture. So again, very trabecular, peripheral palisading of basaloid cells, and you may or may not have a spindle cell appearance. Some areas of our lesion looked a little more spindled. If you have surface urothelium, that should be relatively unremarkable. I don't recall if we actually had any intact urothelium in our case, but either way, you could still see the inverted pattern. The stroma is going to be extremely variable. So there's no one pattern to the stroma that you can really go with. If you do have squamous metaplasia, it should be non-keratinizing, and you can see neuroendocrine differentiation as well. You should never really have pleomorphism or mitotic figures. Mild atypia, however, is allowed. And again, someone could argue with me that there's more than mild atypia in that case, but that's allowable within the inverted papilloma. There's also glandular epithelium, which I feel like that's something that you guys can read about a little more, since our case didn't show that. These are CK20 negative as well as P53 negative. Your molecular, there are rare deletions with 9 and 17, rare FGFR3 mutations, rare loss of heterozygosity. So what does that tell us? If you're pretty sure it's an inverted papilloma, molecular is not going to help you. It's just going to be a very expensive test for the patient. That's not going to say much. Differential includes urothelial carcinoma that involves your von Brunn's nest. Remember von Brunn's nest, I'm going to repeat this 1,000 times tonight, but those von Brunn's nests themselves are normal urothelium. You can have exophytic papillomas instead of inverted, where they're growing in and down. Exophytic is growing out. And pun lump, as we were discussing earlier. These are also resected by transurethral resection of bladder tumors, and your treatment is curative. All right, so case 5.
This is where we get a biopsy for. I'm not seeing any detrusor muscle low power.
Okay.
Maybe. That's something I think important to note if you don't find any.
Yes.
But yeah, it definitely looks thick in that low power, thick in the urothelial layer.
Mm-hmm.
So the higher power. Okay. So it's definitely thickened. It's like 1, 2, 3, 4, 5, 6, 7. Let's just say 7 cells, thick, roughly. The cells look pretty monomorphic, I think.
Mm-hmm.
Yeah, it doesn't look too crazy. Maybe some of them are a little bigger.
Okay.
But compared to like the other ones, not really that as atypical, but let's see. Let me look at this a bit more.
I found like 3 mitotic figures that are not at the base.
Okay, so that's yeah.
Yeah.
Some of these, you know,
Like, see, oh, is that one maybe? Yeah, hard to tell.
This one.
Yeah. So if we were thinking pun lump, because I think that's where your brain was going, is this pun lump versus low grade, right?
Yeah, it's.
So pun lump, no atypia,
No.
and you most definitely cannot have basal, like non-basally situated mitotic figures. They must be at the base. Yeah, the more you search, the more you find. I'm sorry, because I had annotated this. I don't know why it didn't save. Maybe, you know what will probably happen is I'll go back to this and they'll be there and I'll be like, what? Why weren't you here for the lecture?
You know, like on further look also too, it just looks a little disordered.
Yeah.
I don't know about your friend.
There's a little bit, not a lot.
Yeah.
And some of the cells are like slightly bigger, like there's a little bit of pleomorphism.
Yeah, like some of these.
Yeah.
These, it looks a little more like in this section, I think it's more.
Yeah, and that's why it's like, you know, you have to spend time on these. You know, like it can be a lot, like if you have a very big lesion that they've submitted, a lot of small pieces to look at. But yeah, you don't want to mistake pun lump for low grade and vice versa, although technically the clinical aspect of that is the same, but you want to be correct.
I mean, it's not really at the base. I think the base is here.
Yeah.
It's hard to tell, but it's definitely not at the base.
It's floating somewhere, yeah. So this is our low-grade urothelial carcinoma. So this accounts for about 1/4 of your urothelial neoplasms, again, elderly adult males, and there may be microscopic, which means the patient can't see it, or macroscopic gross hematuria. These tend to occur on the posterior lateral walls, and they also like to occur close to the ureteral orifices. So that's where the ureters empty into the bladder. They like to occur there. They're often solitary, and there'll be solid lesions that are firmer than papillomas, and these can be very big lesions. Okay, low grade likes to expand. On microscopy, you're going to have urothelial lined papillary structures. You may or may not see umbrella cells. Remember, your umbrella cells are kind of on top of everything, keeping everything in check. You have loss of polarity, which is an important thing to note. You will have atypia, and you will see mitotic figures. And these can be anywhere from extremely rare, like in our case, there's not a lot of them. And the distribution will be random. And what that means is that they won't all be at the base of the urothelium. They'll be throughout the entire width of it. You'll have some crowding of nuclei. The nuclei themselves tend to be hyperchromatic. You may or may not see nucleoli, so don't bank on that. And you don't count atypia if it's present within the umbrella cells, okay? And remember, umbrella cells are always on the surface. So if you're seeing like huge atypical cells that are definitely not at the surface, they're probably not umbrella cells. Okay, because by definition, they're superficial. For your stains, CK7 positive, CK20 may or may not be positive within all layers of the urothelium, and your Ki67 should be relatively low. Molecular doesn't help you. Diploid, again, basically means it's going to be normal, so don't waste time on that. Differential, is it low grade or is it high grade? Is it really a nephrogenic adenoma, which can occur because of, again, irritation? There's lots of things that irritate the bladder and can cause lesions. Is it papillary polypoid type cystitis, or is it a pun lump? So a lot of things that we've already talked about tonight. And again, resection is through transurethral resection of bladder tumor. And they'll do surveillance cystoscopy, which means every 6 months they'll have the patient come in and they'll take a look at their bladder. And after a period of time, they may move that to annual surveillance. 1/2 to 3/4 of these are going to recur, and about 5% will recur as high-grade lesions. So that's why surveillance is important. You can't just say, hey, we got the lesion out, we're done with this patient. Okay, so that's your low-grade lesion.
Ooh, this part's blue. This part's blue. Okay, I'm going to focus on that later, but looking around superficially, again, not really seeing muscle, but it could be just on high power, but let's ignore that for now. Let's go here. Why is it so blue? We don't like blue.
Yeah.
I mean, very, compared to the other case, you cannot confuse this with a column. Look at that. I mean, that makes even gross.
Yeah.
Well, I don't think this can be.
Yeah.
That's way too deep. But anyways, these cells just look really horrible.
Yes.
Very ugly. Very just nasty looking.
We have gourds. Remember, potatoes and gourds.
Yeah. I don't know. But yeah.
Okay, so what do we have?
High-grade urothelial carcinoma. But I just wanted to find an area where it shows like more of the weird, disorganized architecture. I mean, they're still kind of streaming in one direction.
That you'll have to hunt a little bit.
Yeah.
And one of the caveats with high-grade lesions is that within the bladder is that they fall apart. So it can be difficult to really see that.
I mean, I don't think these are these umbrella cells? They just look way too.
They're on the surface, but they're extremely atypical.
They're very hyperchromatic. Their kind of nuclei is kind of weird looking. I don't know. Audience, please give your 2 cents. These just look so ugly.
Yeah, and you're definitely seeing them in more than just the surface. Yeah.
Yeah, the streaming is not like the loss of like directionality, I guess. It's not as strong as this one, but yeah, those cells I think are just really bad.
So what's something else that we'd want to spend some time looking for? Not necessarily today, but detrusor muscle, right? So
I said I didn't see any at low power. So.
Yeah. So spend some time looking at that since you have your fancy little pictures in your handout that try to help you figure out mucosa versus propria. So this is our high-grade urothelial carcinoma. Again, older adults, 50 plus years old, extreme male predominance. Again, your microscopic versus macroscopic hematuria. Patients may present with infection, and they can have obstructive symptoms as well if the lesion is very large. Grossly, these are going to be exophytic papillary lesions, and ulceration and necrosis is common. These tend to be lesions that are just very friable and falling apart, and they'll be ulcerated, and the necrosis will be usually extensive, and they're pretty gross when they're not fixed. On microscopy, as we were seeing, you're going to see a lot of pleomorphism. So we're not looking at everything being potatoes, everything looking relatively similar. You're going to have gourds. So whether it's zucchini, butternut squash, spaghetti squash, they all look very different. Pumpkins, I guess. Pumpkins because the prostate gland looks very similar to a pumpkin. But anyway, and everything will be urothelial cells. but very, very hyperchromatic, clumped chromatin with irregular nuclear membranes. Nucleoli, if you see them, will be very prominent. And the architectural disarray, so that means like extreme loss of polarity. So what's up, what's down, none of it really makes any sense. But with that, you can see some really complex papillary features. And again, because you'll have those gross papillary fronds when you're dissecting your lesion. You may or may not see discohesion. So that's where these cells are so high grade and they're falling apart. And this is why when we do urine cytology, you'll see those extremely high grade cells within the urine. And you will also see a lot of mitotic activity, and that mitoses themselves may be atypical. This may be associated with surface carcinoma in situ or dysplasia, and carcinoma in situ can be extremely difficult, and I apologize because I know I don't have a case of it on here, but carcinoma in situ can even be single cells. So if you see areas that look inflamed and there's not much urothelium there, spend a little time, take a look and decide is there atypia, is this in situ? And there can also be very dysplasia that's not to the degree of in situ carcinoma. If it's a monomorphic lesion, that's when your nuclei can be rounded, and you can have differentiation. So whether this is squamous differentiation, sarcomatoid differentiation, and again, differentiation we see more with the high-grade tumors than the low-grade tumors. For your stains, CK7, CK20, Ki67 should be a lot higher than what you would expect to see with your low-grade lesions. P16 will be overexpressed. You can see beta HCG as well as estrogen in some of these lesions, so not overly helpful if you're trying to prove that it's positive, and also doesn't mean a lot if it's negative. Your negative stains, for the most part, will be E-cadherin, which it can show some weak staining, but generally it's negative. There will be aneuploidy. You can see overexpression of P52, HER2, which is where your E-cadherin comes in, EGFR, loss of P21, WAF1, P27, KIP1, deletions, 2Q, 5Q, 10Q, 18Q, and gains of 5P20Q. So lots of different things going on, but pretty much what you should take away from that is the P53, HER2, EGFR, and aneuploidy. Those are the big things to pay attention to. Your differential, inverted urothelial papillomas, low-grade papillary urothelial carcinoma, again, that papillary nephrogenic adenoma, cystitis, prostatic adenocarcinoma. Again, most of these are going to occur in men, and what's right beside the bladder? The prostate. So you want to think about that. Prostatic type polyps, as well as viloglandular differentiation. So pictures, again, just showing like the pleomorphism, loss of polarity. The bottom left picture is just showing you that discohesive look where you can have single cells just going into the stroma as well. Treatment, so if it's small, they can try doing a transurethral resection of bladder tumor. They may try doing BCG or intravesicular chemotherapy. And if it's invasive and you see detrusor or muscularis propria, then this is at least a stage 2, and for that they will do a radical cystectomy if it's a female, radical cystoprostatectomy if it's a male, and they may or may not do an ileal conduit or a neobladder, which is where they create a bladder out of a part of the small intestine. In addition to that, they may also do systemic chemotherapy and radiation. Prognosis for these, about 40% will progress to invasive disease. You can see late metastases with urothelial carcinoma as well. And if it's invasive, so when we say invasive, remember carcinoma in situ, then you have invasive, T2 being muscle invasive. Stage is more important than any prognostic factors at that point. And just a lot more pictures of like the gross appearance, the disarray. The bottom right picture is just a really nice example of the desmoplasia that you might see. So remember that blue-gray, almost mixoid type change, but it's a little more blue, is your desmoplasia. Miscellaneous lesions, so ones that don't really fall into any category. This is our last case of the day. So this is case 7.
More biopsy pieces.
Yep.
It's also very blue, very low power.
Yes.
A lot of blood. So, and they all look pretty uniform. So I think we'll just start with any piece and see what we get. Focusing on this one. Ooh, okay. So this is definitely not normal. It's very blue and they're very clumpy together. You can kind of see that they're kind of, even at this power, it seems like they're forming maybe nests almost.
Mm-hmm.
And the cells are small because let's see if we can find a red cell. Yeah, sort of red cell. So this is not that much bigger than a red cell. So it's a very small tumor. And it's kind of like the nuclei are kind of dark, can't really see much features, but they're kind of molding around each other. And they're molding because there's very little cytoplasm to give the cell its shape. So, I mean, this, for all intents and purposes, looks like a small cell carcinoma of some sort.
Okay. What other features do we expect to see with small cell?
Yeah, I don't know. Crush artifacts.
Crush artifact, yes. Excellent. I think some of the pieces show it.
Okay.
But remember, it's biopsy.
Yeah.
So, yeah, there's something that you should see a lot of with small cell. And they may or may not be atypical.
Phone a friend.
Phone a friend. Okay, so I'm the phone a friend. There you go. There's your crush artifact. But again, remember, this is on the edge. It's a biopsy. But yeah, these tend to crush, but they have extremely high proliferation rates. So you're going to see a lot of mitotic figures, a lot of apoptotic bodies.
It's kind of hard. Maybe it's just a projection to see.
Yeah.
Clear features.
Yeah. But really, it's the Ki-67 that's going to get you to the point of this being a small cell carcinoma versus is this just a neuroendocrine tumor? But yes.
A neuroendocrine tumor, I think the nuclei should be a little more open.
They can be, but remember, we still have like your variants of neuroendocrine tumor because you have like your standard neuroendocrine, and then there's your large cell variant. But the Ki-67 is really what sets that apart. Okay.
I'll take your word for it.
So we're in the bladder. So what else do we need to actually call this small cell carcinoma of the bladder?
Well, it's always invasive.
It's always invasive, yes. So you said this is a biopsy, right?
Are we looking for detrusor?
Well, it's invasive already, so that's of less importance. But we don't know what the rest of the lesion looks like, right? So what if this is all the small cell there is and you have 5 centimeters of urothelial carcinoma? Is this still a small cell?
Right, if you have.
So this is probably maybe a 1/4 centimeter of material. But if you have, let's say, 5 centimeters of urothelial carcinoma, is this still a small cell carcinoma of the bladder?
I'm going to say no, but
Okay.
yes.
You're going to say no, but yes, but
I don't know.
that's,
I don't know. That's the wrong.
well, okay, because that just means that then there's something to learn. So the answer is no, you would not. So extremely rare, less than 1%, you know, shockingly. Almost everything's going to be your conventional urothelial carcinoma anyway. Older adults, again, men more than women, and there tends to be history of tobacco use in these patients. These patients often complain of gross hematuria, so we're no longer looking at microscopic hematuria. This is gross, so the patient can see it. They may also complain of dysuria or obstructive symptoms. And even though this is a small cell carcinoma, we do not see hypercalcemia, and we don't see ectopic parathyroid hormone expression, okay? So things that we normally would associate with small cell, like in the lung and stuff like that, you don't see that here. This can occur anywhere in the bladder, but tends to like the lateral wall as well as the dome. And grossly, it's going to look very similar to urothelial carcinoma. Large polypoid masses. The picture I have on the top right, unfortunately, is the lung, because trying to find pictures of small cell carcinoma in the bladder is extremely difficult. So, but that tan yellow fish flesh-like appearance, that's really well depicted in that picture. So I still feel like it's useful to see what these lesions look like. And there may or may not be ulceration associated with it. Again, small cell carcinoma is invasive by definition, right? These are, even though they're carcinoma, they don't necessarily involve the epithelial surface of the bladder. And microscopy, it's small cell carcinoma, so small cell anywhere. You can see this alongside your urothelial carcinoma in situ or conventional invasive urothelial carcinoma. Again, hyperchromatic small to medium cells, with nuclear molding, crush artifact, coarse chromatin, inconspicuous nucleoli. So if you're seeing nucleoli everywhere, this is not small cell carcinoma, and you should not really see nuclear overlap. So you don't get piles of cells, and that's why you're getting the molding, because they are pushing so close against each other that they're really leaving an imprint on each other. There will be lots of mitotic activity, lots of necrosis, and this can actually be really difficult to assess on the biopsy. In this instance, it's really difficult to assess when it's projected onto a screen. It's much easier to appreciate when you're looking at it on a computer screen. And small cell carcinoma, to be truly small cell carcinoma, it must comprise the majority of the lesion. And this is difficult to do on biopsy, because how do you know that the rest of it isn't something else? So our bottom picture looks like it's showing small cell carcinoma with maybe some background urothelial carcinoma. You can see there's a lot of that dirty type necrosis that we associate with small cell carcinoma as well. All right, stains. So a lot of them that you can use: chromogranin synaptophysin, CD56, NSE, TTF1, of course, CK7, CAM 5.2, CK20, EMA, and rarely CKIT. Your Ki67, again, should be really high. So it should be greater than 20%, but usually see it closer to 50%. Something to note is that even though this is small cell carcinoma, synaptophysin and chromogranin don't always play nice, and they may be negative or give you very non-specific staining, which is always helpful when you're not sure what you're looking at. Negative stains, GATA3, which would be positive in regular urothelium, CAA, CD20, CD3. So again, if you were thinking, is this maybe a metastatic lesion? Like, is it lymphoma? CD45 would also be negative. So again, lymphoma, P40, P63. So those are stains that we use for conventional urothelial carcinoma. Molecular, whole bunch of molecular to know, okay? So lots of losses and gains, like individual chromosomes. You can see amplification of your E2F3, deletions of RB1, which is on chromosome 13. TP53 mutations, again, that's chromosome 17. And the TP53 mutations are far more common to small cell carcinoma than they are to conventional urothelial carcinoma. So even though I said that those were associated with urothelial carcinoma, you see them a lot more often with small cell carcinoma of the bladder. The best thing to help you, though, if you're like, man, this really looks like small cell carcinoma, and I'm not sure if it's small cell carcinoma from the bladder, from the lung, from here, there, wherever, is TERT mutations. TERT mutations associated with small cell carcinoma are only seen when it's associated with the bladder. You don't see TERT mutations when it's small cell in the lung or anywhere else. So that is something that will help you with molecular. Again, more stains just showing you the pleomorphism. Sometimes you can get elongation of the cells with like almost like the streaming effect. And the top picture is definitely the really dark blue areas are your small cell carcinoma, and the lighter blue areas, that is conventional urothelial carcinoma, just to make things difficult. Differential, pretty much everything that we listed in our stain. So lymphoma, metastatic small cell from usually the lung, poorly differentiated carcinoma, small round blue cell tumors. So there's a whole bunch of them listed. Synovial sarcoma, large cell neuroendocrine carcinoma, I apologize, as well as your basaloid variant of squamous cell carcinoma. And remember, our squamous cell carcinoma was most commonly seen with schistosomiasis hematobium, but of course you can get squamous cell carcinoma in the bladder for other reasons than that. For treatment, this gets the patient a radical cystectomy, so you want to make sure that you are certain that's what you're looking at. And the patient will also get systemic therapy. And why? Because these lesions tend to be responsive to chemotherapy. Prognosis, it's similar to small cell carcinoma in the lung. So overall, generally poor. Your 5-year survival is only between like 5 to 25%. This is improved when we add neoadjuvant chemotherapy as well as radiation. Your poor prognostic factors include things like advanced age, presentation at height stage, which unfortunately a lot of these are, as well as metastasis. Top picture again is just showing you more of small cell carcinoma, and the bottom picture is just showing you an extremely atypical mitotic figure. So that's all the cases we have for this week. Your challenge cases, we have 12 cases from our bladder lesions. Don't forget to go back to your handout because we also have information about staging of bladder tumors. And if you have any comments, questions, things you'd like to see, things you wish we spent more time on or less time on, please let us know in the comments or at any of our Twitter handles, and we'll get back to you as soon as we can. If you like this video, please give it a thumbs up. If you love this video, please give us a subscribe and a share on social media. And we will see you later this week with our challenge cases.